So as I said, my name is Abdul Shahid. I'm interventional pain specialist anesthesiologist. I've done my anesthesia residency from Oklahoma University and my fellowship from Ohio State University in palliative medicine and pain management, and did interventional pain management fellowship from University of Rochester. Can you hear me okay? Okay, good. From University of Rochester. I've been in private practice since 2011 as an interventional pain specialist. I do cardiac anesthesia, but I stopped that practice in the United States in around 2012, and then restarted it at Tahir Heart Hospital in 2016. And currently I do on average about 100 bypass cases a year with the Tahir Heart team. And my pain management practice is split between Ohio and Tahir Heart, Rabwa. So about 1,000 patients in Rabwa over the span of a year, and remaining time I stay here in the United States and take care of those patients here. I am going to be talking about today interventional pain, non-drug options. This session today is labeled as drug and non-drug options for a treatment of pain. As we know that affliction of pain is of a variety of reasons, a variety of origins, a variety of diagnosis. But if we look at the prevalence, the highest prevalence of chronic pain is low back pain. And I'm going to have to skip a few slides here to keep everything concise as far as we were talking. I'm going to focus on non-drug options. And of the non-drug options for the low back pain, the prevalence for lumbar spinal stenosis is the highest. 1 out of 2 people, 65% of population suffers from low back pain that is coming from lumbar spinal stenosis. So it basically touches every family, and what we see is there are options for it that are non-drug treatments that we just heard that are complementary medicine, but definitely calibrating the body is the key, whether that is complementary medicine is trying to achieve or allopathic medicine is. So in that realm, we have a variety of treatment options, or you can call it our menu for the treatment of lumbar spinal stenosis. For instance, just routine epidural steroid injection, neuromodulation where we use spinal cord stimulator therapy, intrathecal drug delivery system, intraspinous fusion, spacers, PILD, or open decompression. Of these, I'm going to be talking today about the last 2, which are the most innovative and newest treatment options that are available. And I have been involved in this for past 6 or 7 years. The precipitous for this actually I started looking at options other than the traditional menu, which is up on top. When I visited Hazur, after having done my first clinic in Rabwa, and I talked to him about my experience, and he said, "Oh, so आपने इंजेक्शन लगाए हैं वो लोगों की जो हैं वो joints कमज़ोर हो जाएंगे." So that is when I started exploring other options, alternative as PRP and regenerative medicine, and then I started going to treatment training programs for advanced therapies. So the first one that I'm going to share with you is PILD, which is percutaneous image-guided lumbar decompression. Why and how we choose a certain treatment option is based on this study that has come up recently, which is the MIST guidelines. This is the Society of Pain and Neuroscience. This is the society which guides the new budding specialty or subspecialty of pain management for physicians like myself, where we are actually doing surgical interventions to treat these patients with lumbar spinal stenosis. And if we look at this algorithm, As we see, we have a variety of options as non-invasive, such as spinal cord stimulator therapy, to all the way open laminectomy and fusion by surgeons. And then in the middle is the PILD and other options. So PILD is basically to treat the lumbar spinal stenosis. If we look at this cartoon, this shows a normal spine, which is the happy nerves in the middle, and the white dots that are hanging in the spinal cord stimulator, spinal cord CSF fluid, and the ligament is the brown thin line underneath, and the patient is standing erect. So it is basically demonstrating that this is a normal, healthy patient. However, as we age, the statistic states that 1 out of 2 people will end up having this kind of degenerative model. Either one or the combination of all of these 3 things will take place. The thickened ligament, a disc bulge, and facet arthrosis. 1 or 3 or small component of each one. The symptoms that the patients complain about are the pain, numbness, and tingling, weakness with activity, and pain is relieved by sitting down. Very similar to angina for the cardiac patients. When patients have predictable distance that they can walk or predictable amount of time that they can stand, and the pain comes on and it goes away when they sit down, it is basically neurogenic claudication. Neurogenic claudication has to have other differential diagnoses that have to be ruled out before we start treating it. MRI is the number 1. We'll look at the MRI. We'll make sure that this is not peripheral vascular disease, and then we'll go ahead and start treating this patient. If we use PILD, basically what we're doing is we're addressing the thickened ligament, which is the pink ligament underneath, and we're taking bites of it out so that we can relax the nerves that are stuck or compressed. This is a case, this is a patient of mine who came with lumbar spinal stenosis. I did an epidurogram at L5S1, and the contrast is very limited to that level. Then I went ahead above the spinal stenosis level and did another epidurogram, and as you can see, that contrast is also limited to the area to the right of the patient. After doing the decompression, this is a free-flowing contrast showing a lack of stenosis and improvement in patients' baseline disease process. This is a patient immediately after the surgery. This is an outpatient procedure. Patient walks in, walks out. There's no long hospitalization. This is the ligament that was removed by way of PILD that was restricting the nerves, causing lumbar spinal stenosis. This was done here at my institution. This is a similar case in Pakistan, Rabwa at Tahir Heart in cath lab. This patient received this treatment. I wish I could play the. So the video is not playing, but basically it shows the kerosene, which is the instrument, going down into the lamina, and this procedure is done under live fluoroscopic guidance, and the ligament is scraped. And this is the simple setup for the procedure. Ligament is what we have removed from this patient on the left side, and this allows for the patient to have recovery very quickly and symptom relief. This is the evidence for the procedure, and procedure has been going on for about 5 years. We have a large number of data available that is being analyzed. The earlier study basically rendered it superior than traditional interventional options in the menu that I showed you, the less invasive options. This study basically showed that it was superior. 5-year randomized control trial done at Cleveland Clinic demonstrated that 88% of the patients actually did not go on to need surgical intervention for the 5 years. What does that tell us? Degenerative process is there. We are not stopping the regenerative process. Maybe alternative medicine can slow down the degeneration of the spine. But what we're doing is we're removing the offending anatomy and renormalizing it. And this data is pretty convincing for that. Now, moving on to the next treatment option, intraspinous fusion. We have a case of 65-year-old female, obese female, who has facet arthrosis on this X-ray, and we can see that lumbar canal is stenosed and has foraminal stenosis. This patient underwent intraspinous fusion. I have put that intraspinous fusion device at L4, L5. On the lateral X-ray, now that same foraminal narrowing has become open keyhole lateral foramina. And patient improved her radicular symptoms. Patient has been now 2.5 years post-op and continues to do well. This is the size of the incision. This is the literature review regarding intraspinous fusion. Because we don't have too many studies done, it is still considered a grade 2, it is still considered a grade C recommendation. Basically what it is saying is that we do not have enough evidence yet to make it grade A, but as we do randomized control trials in the future, data will either tell us whether this is the primary indication or not. Level of certainty is moderate, and a level of evidence is 1C. 1C basically tells us that we do not have randomized control trials present at this time. However, the data is being collected in the registry, and we'll know more about it as the time goes on. And this is why we do what we do, because we're Ahmadi Muslims, and we have the fire to help humanity, and if we keep that focus, inshallah, we'll continue to succeed in our respective specialties. With that, I finish my presentation, and I will introduce the next presenter, who is our dear Dr. Aladdin, who has just finished his presentation, and I will introduce you to him by reading these credentials. Dr. Irfan Aladdin is board certified in physical medicine and rehab. He is board certified in pain management. He is licensed to practice in New York and New Jersey, and he runs a practice that he owns. Dr. Aladdin.